Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Large Retroperitoneal Lymphadenopathy as a Predictor on Venous Thromboembolism in Patients with Disseminated Germ Cell Tumors Treated with Chemotherapy, by Dr. Srikanthan et al. My name is Tom Poles, and I'm a Professor of Urology Cancer at Bart's Cancer Institute in the UK. My co-author, Maria Dolores Mediano, made a significant contribution to this work. It's estimated that patients with cancer are predisposed to venous thromboembolism, or VTE, with a risk approximately 4 to 8 times higher than age-matched controls. This appears particularly true during chemotherapy or after surgery. Data on VTE-related mortality is sparse in patients with germ cell tumours, but the risk appears low. Therefore, there is a debate about the role of prophylactic anticoagulation therapy to prevent VTEs in this clinical setting. Are the risks of prophylactic therapy, such as bleeding, offset by the reduction of VTE, and does this reduce mortality? The rate of VTE for hospitalized cancer patients runs at 7.8%, and prophylactic anticoagulation therapy is recommended for these patients. However, rates are considered lower in the ambulatory setting of between 0.6 and 3.2%. The largest single study to report on the role of prophylactic anticoagulation in ambulatory cancer patients compared subcutaneous semulareparin or placebo in this population. VTE occurred in 20 of 1,608 patients, or 1.2%, who received semulareparin, as compared to 55 of the 1,604, or 3.4%, receiving placebo. This gave a hazard ratio of 0.36, which was statistically significant. A subsequent meta-analysis of 3,538 patients enrolled on clinical trials explored the role of anticoagulation therapy in outpatient cancer patients and has reported. This meta-analysis showed low molecular weight heparin significantly reduced the risk of symptomatic VTE with a hazard ratio of 0.62, which was also statistically significant. However, there was a 60% increase in bleeding, which was non-significant, and also an unknown effect on survival. The authors concluded that prophylactic anticoagulation could not be recommended in unselected cancer patients based on this data. These recommendations are reflected in the American Society of Clinical Oncology guidelines on thromboprophylaxis for cancer patients. They recommend the use of prophylactic anticoagulation for inpatients, but do not recommend its use in ambulatory patients. They state that prophylaxis may be considered in high-risk patients, which include patients in the post-operative setting and those with myeloma. Karani and et al. Developed a VTE predictive risk model for cancer patients receiving chemotherapy to help define these high-risk patients. This model was retrospective in nature and controversial in its interpretation. The authors analysed over 4,000 patients and identified prognostic factors by multivariable analysis that independently associated with the risk of VTE. These included high platelet count, high lymphocyte count, anemia, the site of the primary cancer, including testis cancer, and increased body mass index. 3 or more of these risk factors were associated with a risk of VTE of 7%. Importantly, these results have not been adopted by the guidelines. In this article, which accompanies this podcast, Srikanthan et al. Attempts to define a GCT population receiving chemotherapy with a high risk of VTE. This task is not trivial, and the authors should be congratulated for taking on this challenging problem. They focus on patients with a greater than 5 centimeter retroperitoneal lymph node tumor mass. These patients have a high risk of VTE on a number of levels. The tumor itself is considered to be at risk of VTE by the Karani score. Moreover, such patients often require major surgery for residual masses. Therefore, the hypothesis that these patients are at a particularly high risk of VTE, irrespective of other risk factors in the Karani score, is sound and worthy of investigation. In this work, the authors identified 216 patients with large retroperitoneal lymph node masses. 10% of these developed VTEs. This number is high compared to those seen in prospective studies of ambulatory patients, which runs at approximately 3.4%. The question is whether these patients are at a particularly high risk, justifying routine prophylactic therapy and deviating from the guidelines. The fact that this single risk factor appears to be as powerful as the Karani score in predicting risk is noteworthy. The problem is the Karani score has not influenced guidelines, and therefore the data presented here would need to be more robust to convincingly change practice. Also, there are concerns that when one examines the reproducibility of the data in the validation cohort, where the retroperitoneal lymph node mass size of greater than 5 centimeter did not reach statistical significance, one is concerned. The numbers were exceptionally small in this validation cohort, which are usually larger than the corresponding training set. It seems likely, but not inevitable, that had the numbers been larger, these results would have reached a level of statistical significance. This results in a bit of a dilemma. Do we go with what makes sense, namely a high risk of VTE in a young population with a curable cancer, or should we be more circumspect due to the need for a robust validation data set, also the lack of survival data, and the unknown risk of bleeding? Although it may be tempting to place greater weight on VTE concerns in this population, doubts about the validation cohort lend ammunition to those who argue this story is incomplete and cannot yet be adopted in routine clinical practice. It's therefore unlikely that these results will influence guidelines, especially as other compelling randomized data have not gained widespread acceptance. So what does the medical community need to see to change their mind? Validation would be important, and some quantification on morbidity and mortality would also help. Until more definitive data are provided to clarify these issues, the debate will go on. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.